Contaminated soil may also be a source of toxic exposure. Ingestion is a common route of exposure, especially in young children. Vegetables and other edible produce grown in contaminated soil may also accumulate contaminants. So common soil contaminants include lead, dioxins, heavy metals, and pesticides. There are also emerging contaminants of concern, such as PFAS, again, as well as endocrine disrupting chemicals. Next slide. So after taking a thorough exposure history, clinicians should explore whether there might be a connection between an exposure to a potential environmental hazard and specific symptoms. This can actually be very challenging, and the answer might not necessarily be straightforward. So here are a few general principles to consider. First, consider the location. Do the patient's symptoms seem to subside or worsen when they are in a particular location? For example, do their symptoms occur more when they're at home, when they're at school, at work, in a daycare or playground, or a specific neighborhood? Also consider whether there's a temporal relationship. For example, do the symptoms improve or worsen at any particular time, whether it's a time of day, whether it's a weekday versus a weekend, or a particular week or season out of the year. Consider the activity that the individual is performing that might be associated with the symptoms. Did the symptoms worsen with a task in the workplace, for example, or while they were playing outdoors, while a child was in school or engaging in a hobby? And finally, consider whether other people who are present in those same settings have similar symptoms as well. Next slide, please. Once a potentially harmful environmental or occupational exposure is identified, it is often helpful to consult with professionals with specialized expertise. For example, medical toxicology physicians are specialists who are dedicated to the evaluation and treatment of poisoned and envenomated patients. Their expertise includes the medical management of the adverse health effects of medications, occupational and environmental toxins, and biological agents. Poison centers are another good source of reliable information regarding substances and medical management. Currently, we have 55 poison centers spread out across the United States that provide prompt and accurate poison information to the general public as well as healthcare providers, 24 hours a day, 365 days a year. You can reach your local poison center through the Poison Help Hotline at 1-800-222-1222. And poison centers also educate healthcare professionals in the areas of clinical toxicology, poisoning, epidemiology, poison prevention, toxicological diagnosis, and medical care. Poison centers also play a very important role in public health, tracking poisoning sources such as household products, food and beverages, drugs, and medicine in the setting of outbreak investigations. Next slide, please. Occupational and environmental medicine is a medical specialty dedicated to the diagnosis and treatment of work-related and environmental injuries and illnesses. Occupational and environmental medicine physicians also identify and mitigate workplace hazards to prevent illness and injury. They often work together with occupational health nurses who also might be present at work sites and have that specialized expertise and experience that might be very valuable to the primary care clinician. Also, we have industrial hygienists who recognize, evaluate, and control workplace-related factors that may cause illness or impair the health of workers or community members. Industrial hygienists can be very helpful in assessing whether a significant exposure has occurred. Next slide. Diagnostic lab testing and other workups should be guided by the patient's history, physical exam findings, and the signs and symptoms. It is important to understand the correct indications and proper interpretation of tests before ordering them. And if tests are ordered without a clear rationale, sometimes the results can be very challenging to interpret and are often not helpful in medical management. For example, urine testing may be considered to evaluate patients for arsenic exposure. Very often, heavy metal testing is done with 24-hour urine collection in a special acid wash container. However, arsenic can exist in different forms. There are organic forms of arsenic as well as inorganic forms of arsenic. Organic arsenic, such as arsenobutane, is present in seafood, and it's typically not considered to be harmful. But high arsenic levels can be detected if the individual was not counseled to abstain from eating seafood in the few days prior to sample collection. Also, it is very important to perform speciation to distinguish between organic and inorganic forms of arsenic. Before ordering any diagnostic testing, it may be useful to consult a medical toxicology physician or an occupational and environmental medicine specialist to obtain further guidance regarding the appropriate diagnostic testing to pursue. Next slide, please. Sometimes, as we know, patients might seek out lab testing on their own in their search for an explanation for their signs and symptoms. There are many commercial tests and labs out there on the market that are increasingly available to consumers, sometimes using blood, hair, or urine specimens. And these are often marketed as tests for unspecified toxins, heavy metals, or so-called toxic mold. However, in many cases, these tests are often not actually validated for clinical use. Even if a lab is certified, CLIA regulations do not address the clinical validity of the tests that are performed. FDA clearance or approval of clinical tests might provide some degree of assurance of adequate analytical and clinical validation, safety, and effectiveness. Use of unvalidated lab tests can sometimes lead to incorrect diagnosis, as well as unnecessary, inappropriate, or even potentially harmful medical interventions. Sometimes they are used to justify the use of unproven or alternative therapies, and these results can also spread misinformation and fear among individuals and peers in the workplace. They can also lead to unnecessary or inappropriate environmental and occupational evaluations. When patients present to the office with results from unvalidated lab tests seeking medical guidance, these conversations can be particularly challenging. So it is important to inquire and listen to the patient's motivations for seeking the testing, acknowledge their concerns, and respect their autonomy. Sometimes criticizing the lab or the test that is performed upfront might not be helpful and can actually lead to mistrust. So instead, the conversation should really focus on how the patient feels and their fears, and the information gathered in a thorough exposure history can help us assess whether diagnostic testing is indicated. And using a shared decision-making approach, we can formulate a diagnostic and treatment plan that would be acceptable to the patient. Next slide, please. Fear of chemicals and unspecified toxins is very common. There are also many unproven and alternative so-called detox therapies that are widely available. Clinicians should advise patients of the risks of using these unproven therapies. For example, chelation treatments done without the proper indications have been associated with significant morbidity and even mortality. Therapies such as the use of antifungal medicines for so-called toxic mold are also not based on solid evidence. Antifungal therapies are really just indicated for treatment of diagnosed, confirmed fungal infections. Dietary supplements and herbal products might contain undisclosed ingredients, which can include contaminants like heavy metals and pharmaceutical agents. There's very little regulation of dietary supplements. Post-marketing reporting of adverse events by dietary supplement manufacturers is only required for serious adverse events, such as those resulting in hospitalization, significant disability, or death. Next slide, please. It is also important to stress to patients that the detection of a substance, either in clinical tests or in environmental samples, does not equal toxicity. So the health effects of a substance depend on the route of exposure, the dose, concentration, and time. When we refer to the relevant time of exposure, this can include factors such as frequency and duration of the exposure. Adverse effects are also based on organ system toxicity due to the specific mechanism of action of a substance. Next slide. Therefore, it is important for clinicians to communicate risk appropriately to patients. Risk communication is the sharing of science-based factual information about a real or potential hazard. Good risk communication can improve understanding and guide appropriate decision-making, and it can calm people's fears and respond to criticism. This can be especially challenging when dealing with environmental contaminants and chemical disasters. There are some communities that might have a higher degree of mistrust in general due to a history of environmental injustice, including issues like environmental racism, prior negative experiences with healthcare providers, and other types of inequality. Also, the involuntary nature of environmental exposures is often emotionally charged, with many people harboring feelings of anger or fear. People would say, no, I did not choose to be exposed to a pollutant in the community. Someone did this to me. So although good risk communication does not always make a situation better, we know for a fact that bad risk communication will surely make a situation worse. Next slide. So here are a few tips for risk communication. And risk communication is a much broader topic. It does require a lot more thought and practice and training than we can fit into this webinar today, but just a few things to consider. It is often very helpful to plan difficult conversations carefully in advance. We should, of course, speak clearly and compassionately and be honest and open about what is known and what is unknown. It's helpful to just say to the patient, here is the situation. This is the exposure we know about, or the exam finding or test result. And patients want to know whether they or their children or other loved ones are either at risk or are not at risk, either now or in the future. People want to know about what actions they can take. So address whether they do need to do something now or whether they don't need to do something, and then what the options are, whether it's for further workup or treatment. It's often helpful to accept and involve not only the patients, but also the family members and other community members in the case of something that an entire community might be exposed to, and involve them as partners in these difficult conversations. And also work with other credible sources, other public health professionals and medical professionals to provide reliable information and resources. Next slide. So I will leave you with this. Again, I covered many different topics, and we do have resources for clinicians on the CDC and ATSDR website, including taking an exposure history and an exposure history module specifically for pediatric providers as well. And as I mentioned before, we also have a sample exposure history form that you can use in the clinical setting. And with that, I will be happy to take any questions. And thank you very much for your attention.
Thank you, Dr. Ye. We had one question come in. I noticed you are including dangerous plants. Is there a comprehensive resource for plant-based toxins?
Well, as you know, there are many different types of plants out there. And I would say there are certain books out there dedicated specifically to toxic plants. I would say that also would depend on your local region. There are many different ecosystems that vary a lot, and the types of plants that are found are different. And very often when we're dealing in the clinical setting, we're talking about herbal supplements or herbal remedies and potential adverse effects. So yes, there are several specific books out there. If anyone is interested in a particular type of question, I'll be happy to provide specific resources to answer those questions. But I think it's a little hard to say that there's one comprehensive encyclopedia of all toxic plants that is relevant to every part of the world and every geographic region.
Thank you. So to keep us on track with our time, it is, if you have any other questions to follow up with Dr. Ye, please email ehnexus@cdc.gov. Welcome back, everyone. And now we will hear from Dr. Art Chang as he discusses childhood lead poisoning and prevention. Dr. Chang?
Great, thank you. I'm here again, and thanks again for joining and spending your afternoon with us. My background is that I'm a practicing physician. I'm board in emergency medicine and medical toxicology. And in the next few minutes, we will be discussing childhood lead exposure, prevention, diagnosis, and management. Next slide, please. So lead is a natural occurring metal that can cause adverse health effects, both acute and chronic exposure. So people are exposed to lead by eating lead paint chips, ingesting contaminated food or water, and by breathing in lead dust. So even very low levels of lead exposure have been shown to negatively affect the child's health and development. Next slide, please. Because lead is a developmental toxicant, children are at higher risk compared to adults. And that's a reason why prevention and screening efforts are more focused on children. So at high levels, and most often this occurs when we see acute exposures, which result in very high body burden of lead. Children experience severe neurological problems such as confusion, seizures, and other neuropathies. They can also have GI problems such as abdominal pain, nausea, and vomiting, and then even renal abnormalities. So at low lead levels, which we see sometimes with longer but more chronic exposures, children can experience things like anemia, cognitive development delays, slow growth, hearing and speech developmental abnormalities. Because lead has no biological use in the body, it's why you always hear the term, there is no safe level of exposure to lead or safe level of lead in the blood. Next slide, please. So as already mentioned, children are more vulnerable to lead exposure because of several reasons. First, they have developing neurological systems, which is most important target for lead exposure. Also, young children have age-related behaviors like putting objects in their mouths and crawling on the floor that makes them more prone to being exposed to lead. And because of their body size, they proportionally absorb more inorganic lead that is ingested compared to adults. Next slide, please. So as you can see on this graph, over the last 40 to 50 years, children's blood lead levels have declined in the US, which is a great public health victory. So this large decline came between the late 1970s and the 80s, and was due to several legal and policy initiatives, like the banning of lead from automobile gasoline in 1975, and also residential paint in 1978 in the United States. Next slide, please. So despite declining lead levels in children, there are still disparities in lead exposure today. So we know that higher blood lead levels are more prevalent among some children from some racial and ethnic minority groups, those living in households with lower incomes, and those living in housing that has leaded paint, and children from racial and ethnic minority groups that live in environments which have greater likelihood of lead exposure, such as unabated substandard housing. Next slide, please. So we still have more work to do in terms of prevention. Millions of children are still exposed to lead today from multiple sources. And there's a growing scientific evidence that adverse health effects are being identified from lead levels at increasing lower levels in the blood. Next slide, please. So I believe this was covered by Dr. Ye in the previous talk, but this is an infographic from UNICEF, which shows the many ways that children can be exposed to lead. However, in terms of numbers, children in the US today are primarily exposed to lead from paint in homes and buildings built before 1978, contaminated soil from deteriorated exterior lead-based paint, car and airplane exhaust, and factories that still use lead. There's also a possibility of getting lead from contaminated drinking water, which is delivered through lead plumbing materials. Some of the other sources that are mentioned on this infographic, and also I had to cover by Dr. Ye previously, are toys and jewelry, particularly those made in other countries where the lead regulations are not as strict as the ones in the US. There's also other antiques and collectibles that may fall in this category as well. Lead poisoning had been described before from imported candies or traditional home remedies. And then another source for today, which are jobs and hobbies that involve working with lead-based products like stained glass work, and this is mainly in the parents or other family members, and especially if adults work in an industry that have occupational lead exposure, they may be bringing lead home with them. Next slide, please. So the key routes of lead exposure are inhalation of lead dust and particles, and ingestion of contaminated paint chips, lead dust, and other products that contain or are contaminated with lead. And as I mentioned before, young children often put their fingers and objects in their mouths, so it makes them particularly at risk of lead exposure, and then also those negative health consequences. Next slide, please. So there are two public health actions that can prevent lead poisoning. Primary prevention is the removal of lead from a child's environment, and it is the most effective way to ensure that children do not experience harmful long-term effects of lead exposure. Secondary prevention includes early screening using blood lead testing and follow-up care and other interventions as well. So this remains an essential safety net for children who may already be exposed to lead. Next slide, please. So methods of primary prevention include having homes built before 1978, inspected for lead paint, and if lead paint is present in other places such as the home or drinking water plumbing, the owner can then contact a certified lead abatement specialist to address those hazards. If the house is being rented, the renter can ask their landlord to have lead hazards removed from the home. Cleaning floors, window frames, window sills, and other surfaces regularly to reduce leaded dust is something also that you can do. Using soap and water to wash children's hands more frequently, as well as toys. Leaving shoes by the door or outside. Covering bare soil with grass, mulch, or wood chips. And also preventing children from playing in bare soil that may be contaminated with lead. So these are, again, all forms of primary prevention. Next slide, please. So now in terms of secondary prevention, which is screening, and again, this will be done after exposure had already occurred. So the blood lead level is a standard of care for a diagnosis, whether a child has been exposed to lead previously or currently. So there are two types of blood sampling tests that can be used. Either one needs to be collected very carefully to avoid environmental contamination because that can alter the results. And CDC has published guidance on proper sample collection of blood. So you can order a venous or capillary sample, and each one has their pros and cons. The capillary sample, the cons is that it is more prone to environmental contamination. So in this test, a child's finger is pricked or heel is pricked, and a very small amount of blood then is collected in a micro pipette-like device. The issue is that if there's some lead either on the skin where the blood is being collected, since you're waiting for those drops of blood to get inside the capillary tube, that is a potential source for contamination. The pros is that this is a very fast procedure that can be done, and there are also point of care tests and devices that can be used and can give you a blood lead level done even within the same visit of the patient. Also, this may be less traumatic to a young child. You can also then order a venous blood lead test. And this one, the pros is that it's a lot more accurate because the technologies as used. It is a send-out test, however, so it's sent to a regional laboratory. And the results are a lot more accurate in terms of level of detection for lead. The negatives are that it is a send-out test, so there's going to be an increased turnaround time. And then also the collection has to be done using a vacutainer, which makes it easier and less prone to contamination as well. If you order a capillary sample test and that test comes back with an elevated blood lead level, you may need to order a second test to confirm that using a venous blood lead level. Next slide, please. Because children with lead exposure may not show any symptoms. Children enroll in Medicaid, who are likely the children with the higher risks that I spoke about a few minutes ago, are required to get tested for lead at ages 12 and 24 months, or age 24 to 72 months if they have not had a record of being tested previously. So for other children, CDC recommends focusing testing efforts on those that you suspect them to be at risk of lead exposure, while also following your local state or local requirements. However, please note that some states have implemented universal testing for all children. Next slide, please. So the utility for obtaining a child's blood lead level is because it guides your next action. If it is low, you can provide anticipatory guidance and monitor your patient's growth and development as you normally would otherwise. If it's high, you can assess the child's symptoms and provide a referral to your state or county's health department for a home-led environmental assessment to determine the source. If it is very high, you may need to initiate medical treatment by referring the child to a specialist. And I will speak on this a little bit more later. Next slide, please. So what should you do if your first level from a capillary sample returns above 3.5 micrograms per deciliter? So at this point, you should order a venous sample as a confirmatory test because that's a gold standard for determining medical management. As I mentioned before, a venous test is a send-out test that's more accurate because it's analyzed using more sophisticated laboratory technique as compared to a point-of-care capillary sample test. And a venous test also controls environmental contamination, which may be present in a child's finger or testing environment. So looking at this table that I have here, what is showing us is that if your initial level is higher, then what you want to do is get that confirmatory venous test faster to ensure the proper medical treatment. Next slide, please. So in the following slides, we're going to review CDC's recommended actions for follow-up care and case management for children based on their confirmed blood lead levels. Keep in mind that providers should consider their state or local guidance when making decisions on the next course of action. So for first category, with children that have blood lead levels below 3.5 micrograms per deciliter, so I want to reiterate that 3.5 micrograms per deciliter is the blood lead reference value that CDC has recommended about 2 years ago. And the way that this is determined is using national data from a representative group of children, and levels above 3.5 represent the highest level of exposure in the US population. So that is above 97.5 percentile. So if you have a child that has a BLL that's less than 3.5, you should still provide education about common sources of lead, like I said before, as anticipatory guidance, and how to prevent further or prevent exposure from lead. During your well child visits, you want to check like you normally would their development and make sure they have age-appropriate milestones that are being met. During well child visits, discuss diet and nutrition with a focus on iron and calcium intake. And as Dr. Ye had mentioned, because we know that in states where children are malnourished, they may absorb more lead from their diet. And then you may need to conduct follow-up blood testing at recommended intervals based on a child's age. If this child is enrolled in Medicaid, again, they need to have they may need another test at 24 months. Next slide, please. So for the next group, for children with blood lead levels between 3.5 and 19 micrograms per deciliter, a healthcare provider should follow recommendations for children with blood lead levels less than 3.5 micrograms per deciliter that we discussed in the previous slide. And the important action here is to make sure that those test results are reported to your state or local health department, which may also include reporting additional pertinent information. So for example, some states ask whether the result was obtained from a venous or capillary sample. So for this group of children, you want to obtain an environmental exposure history to identify potential sources of lead using the presentation Dr. Ye had just given. And if you missed this, we will make this webinar available as a recording in the next following days, so you can review that at your leisure. For children that test above 3.5, you want to refer them to your health department for an environmental investigation of the home to identify potential sources of lead using a local public health guidance. So during an environmental investigation, professionals that perform lead screening in the environment check the child's home for any possible causes of lead exposure and also recommend ways to prevent further exposure if a source is identified. Of note, there are certain BLLs that may not trigger an investigation, and that may change depending on your state or local area where you live. Also, nationally, levels less than 5 micrograms per deciliter may not trigger a Department of Housing and Urban Development, or HUD, environmental investigation. More importantly, I will cover this in the next few slides, is that you want to schedule a repeat visit with that child so you can obtain another blood lead level to make sure that this child's environment is being controlled and those levels are decreasing. Next slide, please. So for children with a blood lead level between 20 and 44 micrograms per deciliter, a healthcare provider should follow recommendations for children with blood lead level less than 19 micrograms per deciliter that we covered earlier. Starting here, what you want to do is be more careful and take a more thorough history and perform a more thorough physical exam, because you want to assess the child for signs and symptoms related to lead exposure, like I mentioned before. So those could be anemia, it could be GI symptoms, it could be some cognitive issues, it could be some neurological symptoms as well. So you want to arrange or refer the family for an environmental investigation of the home, so that the lead hazard can be identified and reduced. Can we go back? Okay, let's see. I'm sorry, I think, are we on 107? Okay, next slide, please. Okay, so also for this group, you may consider ordering an abdominal X-ray to check for lead-based paint chips or other radiopaque foreign bodies. And this will be very important for young children who tend to swallow or eat non-food items. You also want to contact a pediatric environmental health specialty unit, commonly referred to as PACU, and then also a poison control center. So more on PACUs, they provide information on protecting children and reproductive age adults from environmental hazards. They work with healthcare professionals, parents, schools, and other community groups. And we will drop their website on the chat. Okay, next slide, please. Okay, so for this group, we will discuss recommended immediate actions above 45 micrograms per deciliter. So this is an likely acute lead poisoning, and it's a medical emergency. So as soon as possible, what you want to do is follow all the previous recommendations for the lower blood lead levels, but again, perform a complete history and physical exam, including a very detailed neurological exam. You need to perform an X-ray to rule out any foreign bodies that may contain lead. And if these are found, the child may need to be referred to a hospital for GI irrigation so that foreign body can come out. And the reason is that for the first thing that you need to do to treat lead poisoning is to stop the exposure. Very importantly, if a patient or the child exhibits any signs of severe lead poisoning, which includes neurological dysfunction such as confusion, weakness, seizure, coma, severe GI symptoms or abdominal pain, again, they need to be referred to a hospital, likely may require hospitalization, and they need to obtain a consultation with a medical or clinical toxicologist who's a specialist in the treatment of lead poisoning. Other children that may require hospitalization could be that if a child's home is not lead safe, in terms that environmental assessment may take time. Again, because we need to stop all exposure to lead at this blood lead level, they may require to be in a safer environment, such as the hospital. And after GI decontamination has been done, children may need chelation therapy. And again, these are very specialized medications that will require further blood lead levels with faster turnaround times. And there are several of these which can be given by mouth, and some are given intravenously, which means that they need to be given in a medical facility or hospital. Once the child arrives at the hospital, hospital physicians can call a poison control center for medical advice, or the PACU, as I previously mentioned. Okay, next slide, please. So when do you bring back children after those previous actions were performed? So this slide shows a recommended period for the next routine follow-up testing to make sure that your medical interventions are working. The important thing to note is that you need to use clinical judgment based on signs and symptoms, or the risk of exposure has changed. So this schedule, again, more obviously is useful for lower venous blood lead levels because, as mentioned previously, levels above 45 micrograms per deciliter is a medical emergency. As you can see on this slide, you may need to monitor additional blood lead levels for a few months, even after you obtain the repeat blood levels which are declining. Next slide, please. So this slide lists some useful clinical resources. The first one is CDC recommended actions based on blood levels, which I explained. And again, you can find this on our CDC website. Also, the American Academy of Pediatrics has a lot of information on lead exposure and recommendations. I already mentioned the Pediatric Environmental Health Specialty Units, which also has additional web-based training and other resources such as tools, which can help with the diagnosis and management of lead poisoning in children. And then finally, you can always call your local poison control center. They have medical toxicologists on staff ready to assist for answering any questions. And most of them are open and available 24 hours a day. Next slide, please. So for my last slide, I want to highlight an example of the importance of lead screening, which was seen in an incident earlier this year. So in late 2023, early 2024, there was a lead and chromium poisoning outbreak that was linked to cinnamon applesauce pouches, which was distributed nationwide. So our division led the investigation here at CDC and found that it spanned at least 44 states in the United States. And the CDC, the FDA, and state and local partners investigated this link, which caused blood lead levels as high as near those that you would consider immediate and urgent emergencies. So for any of you that may be in the audience which were involved in this outbreak, I want to thank you for your help. And with that, I believe I'll take any questions.
Thank you, Dr. Chang. We had some questions come in. The first one says, what should you do if after chelation the levels do not go down? What would be the next step?
If after chelation therapy the levels don't go down? Yes. So the issue there is likely there's still ongoing exposure. So a couple of things. One is you have to make sure that the environment is free of any lead. After that environmental scans is done by the environmental health specialist, if that level does not go down, the other possibility, especially in older children or adults, would be that they have some sort of retained lead in their bodies. We see this a lot after gunshot wounds, for example, where depending on that lead projectile, if it's near a joint, it may absorb lead. That lead can be absorbed into the bloodstream, and that's what you're measuring. If that's the case, then you will need to refer them to an orthopedist, as well as to make sure that they're being followed up by a medical toxicologist so that appropriate care can be given. Does that answer your question?
Thank you. Yes. Another question we had, what should clinicians do if a child has persistently high lead levels without an identified source of exposure, such as lead paint chips or use of lead-containing bulk remedies?
So this is similar to that first question that we had. Again, the first step is to make sure that that environmental assessment is done. And if there's nothing identified, you probably have to, play detective. So for example, you may have to consider that there's take-home lead from the parents. It's been reported before that people that go to indoor firing ranges, because a lot of bullets are made out of lead, that there's lead that's being brought home in their clothes or in their shoes, and that could be a source of lead. If you have very small amounts of lead, it may not be detectable by that first environmental health investigation. However, I want to tell you that those environmental health specialists are experts, and because we work with them, routinely, they most often always get to the bottom of what the source is. Some sources may be unexpected, like we had mentioned before. So, for example, it could be spices. Turmeric had been contaminated with lead before. So what one environmental health program did was they actually were able to do a survey of what the child ate and found commonalities that several children in their community were being exposed to lead from spices. So things like that, I think it will be very useful, but they would give you the next, the next set of actions to do if they could not identify the source.
Thank you. Another question that we had come in. What if a child needs chelation, but I have no experience prescribing chelating medications? Where can I learn more about proper agents to use, indications, and dosing?
Yes, that's a great question. So those two resources, I think, are the most useful. The first is poison control centers. So many of them are associated with outpatient clinics that are attended by medical toxicologists. So you can refer those patients there, and they will take care of ordering and making sure that the child receives the right medication and dose and therapy. So going back to the medications, so chelation therapy, again, is used when levels are very, very, very high, above 45 micrograms per deciliter. And the reason is because at very low levels of lead, those chelation medications don't work as well because they remove a certain amount or percentage of the lead in the blood. So if you can see, if you have a level of 50 and you remove 50%, you're dropping it down to 25. But if your lead level is 5, you're only dropping that level to 2.5. So that decrease in the amount of lead being removed is not indicated. So the important thing there is that you want to make sure that you first stop the exposure, and second, that you can refer that patient to see a specialist that knows when and how to use that chelation therapy. And then I'll talk a little bit more about chelation medications. So there's only one that you can give by mouth that's FDA approved in the US, and it's called Suxamar. It is a therapy that has to be started, and you have to monitor blood lead levels. The dosing is complex. It is very expensive. A lot of patients that I've seen in a medical toxicology clinic could not afford this medication, or certain pharmacies may not stock it and they have to order it. So there's going to be a delay of when you can get it. So that's a reason why it's very important that a assessment is done by a specialist, and then at that time they find out that indeed that patient requires chelation therapy. The remaining medications for chelation, they're all given either intravenously or intramuscularly, which means that they likely need to be hospitalized. There's a lot of side effects with those chelation medications, one being that they can remove a lot of minerals from the body. There's been some reports with certain ones that can cause arrhythmias, cardiac arrhythmias, because they remove other electrolytes that are needed. And then very rarely, we can also see some redistribution of lead into areas such as the CNS, into the brain. So using those more advanced chelation medications, would be probably recommended to be in a hospital setting.
Thank you. I think we have one more question, and then we will wrap up for a break. What would you do if an X-ray shows paint chips or foreign bodies? Would endoscopic removal be possible, or is there some way to wash it out?
That's a great question. So we usually attempt whole bowel irrigation. And the way that's done is that we use basically what we use for a prep for colonoscopy. So this is something like, Miralax, other medications that in essence will just, excrete the lead out the other end. The issue is that this has to be done likely in a medical facility because the amount of gold lightly that a child has to drink is pretty high. So we usually, we start probably a liter or more. And sometimes because it's not palatable and depending on the symptoms that the child is having and the amount of lead in the gut, when we need to put an NG tube and then put the gold lightly whole bowel irrigation through that so that it can be washed out. And then again, you want to make sure that you get a follow-up X-ray to make sure that that lead is indeed removed. Endoscopic removal, that works well for things like a swallowed, fishing weight or large object. Certain times, those may be more challenging to remove via whole bowel irrigation, but things that are very small or very highly distributed in more than one area, like paint chips, whole bowel irrigation, may be the first thing to do.
Thank you, Dr. Chang. So that will wrap up our questions for this session. And I know there were some questions that came in just a moment ago. If you have follow-up questions, please feel free to email the ehnexus@cdc.gov, and we will forward them to the appropriate SME. Welcome back, everyone. Our next presenter is Dr. Andrea Winquist with a discussion on PFAS. Dr. Winquist?
Hello, we can go to the next slide. Per and polyfluoroalkyl substances, often called PFAS, are a large group of thousands of manufactured chemicals. Different groups use different PFAS definitions, with some definitions being broader than others. However, in general, PFAS are chemicals that contain fully fluorinated carbon atoms, which means that they have fluorine attached to the carbon rather than hydrogen. The fully fluorinated carbon atoms are often in chains. PFAS vary in several features, including the length of the carbon chain, the degree of fluorination, presence of side chains, presence of functional groups and ether structures, and some definitions also include structures with rings. Next slide. These are some examples of the more commonly studied types of PFAS. They include perfluorooctane sulfonic acid, which is commonly called PFOS, perfluorooctanoic acid, which is commonly called PFOA, perfluorohexane sulfonic acid, which is commonly called PFHXS, and perfluorononanoic acid, which is commonly called PFNA. These are the PFAS with the highest concentrations measured in the U.S. National Health and Nutrition Examination Survey, or NHANES, which is a nationally representative survey that is conducted annually to assess the health and nutrition status of adults and children in the United States. NHANES includes collection of blood samples that are tested for many environmental chemicals, including PFAS. However, the types of PFAS listed here are just some examples of the thousands of chemicals that are classified as PFAS. Next slide. PFAS have several unique properties. They repel both water and oil. They're non-flammable and are highly stable. They're resistant to degradation, have low reactivity, low surface tension, and a low dielectric constant, meaning they have a low ability to store electrical energy, among other properties. And these many properties make PFAS useful in a wide variety of applications. Starting in the 1940s, PFAS have been used as water, oil, and stain-resistant coatings for fabrics, leather, carpet, and paper products, including food packaging, and in floor polishes, cleaning agents, latex paints, inks, ski waxes, cosmetics, hair conditioners, nail polish, sunscreens, dental floss, and other personal care products. They're used as metal plating and in the manufacture of nonstick cookware and electronics. They've also been used in firefighting foams and in some medical applications. They have many other industrial uses. Next slide. PFAS production started in the 1940s and peaked in 1988 to 1999 for PFOS and in 1995 to 2000 for PFOA. Next slide. One of the first hints that PFAS might be a concern for human health was the identification of organofluorine compounds in human blood in 1968, which is something that would not occur naturally. In CDC's National Health and Nutrition Examination Survey, they started measuring PFAS in human serum in 1999 and demonstrated that almost everyone in the US had detectable PFAS levels in their blood. Next slide. So how are people exposed to PFAS? In some communities, such as communities that are near facilities that have manufactured, used, or handled PFAS, drinking water has become contaminated with PFAS. In those communities, drinking water is the main source of human PFAS exposure. And this includes communities that are near some factories, airports, military bases, wastewater treatment plants, farms where sewage sludge was used as fertilizer, landfills, and incinerators. However, human PFAS exposure also occurs through food, such as meat, dairy, or vegetables produced in areas with soil or water contaminated with PFAS, and fish caught from waters contaminated by PFAS. As was mentioned previously, PFAS are also used in some food packaging materials, and PFAS can migrate from the packaging materials into food when these materials come into contact with the food. And that can be another source of human PFAS exposure. PFAS exposure can also occur through the air as a result of releases from or at facilities that manufacture or use or handle PFAS, like those listed above. Because PFAS are used in many consumer products, PFAS exposure can also occur from exposure to residue and dust from those products. Some people have high occupational PFAS exposure, such as employees at facilities that manufacture or use PFAS. And finally, PFAS exposure can occur in utero and through breastfeeding from mothers who have been exposed to PFAS. Next slide. Because of concern about PFAS, during 2000 to 2002, 3M, which was a major PFAS manufacturer in the United States, phased out production of PFOS and related chemicals. During 2006 to 2015, EPA worked with several PFAS manufacturers through the PFOA stewardship program to phase out the use of PFOA and related chemicals in the US. However, those legacy types of PFAS have been phased out. Although those legacy types of PFAS have been phased out, they've been replaced by newer types of PFAS. Next slide. So why is there concern about PFAS? First, PFAS are very persistent in the environment. Some PFAS can break down to form other PFAS, but many types of PFAS, including PFOA and PFOS, essentially do not break down in the environment. So they've been accumulating in the environment over time. In addition, some types of PFAS have long half-lives in humans, including PFOA, PFOS, and PFHXS, which are sometimes called legacy PFAS. The half-life has been estimated to be 2.1 to 8.5 years for PFOA, 3.1 to 7.4 years for PFOS, and 4.7 to 15.5 years for PFHXS. The half-life is the amount of time that it takes for the concentration of an agent to be decreased by half in a biological specimen, which in this case is serum, in the absence of ongoing exposure. So this means that once people are exposed to these types of PFAS, they stay in the body for several years. Other types of PFAS, including newer types of PFAS, such as Gen X, have shorter half-lives. That means that they do not stay in the body as long, but it does not necessarily mean that they're less harmful. Just for background, Gen X is a set of chemicals primarily composed of hexafluoropropylene oxide dimer acid and its ammonium salt that's been used as a replacement for PFOA. Gen X chemicals have only 6 carbon atoms in the carbon chain rather than the 8 carbon atoms of PFOA, and Gen X also has an oxygen atom that interrupts the carbon chain. Gen X is used as a replacement for PFOA, but much less information is available about its health effects. Nearly everyone in the United States has measurable amounts of PFAS in their blood. As shown in the graph to the right, serum levels of some PFAS in the United States have been decreasing since production has been phased out in the United States, but many PFAS are still detectable in over 95% of the US population. In addition, there is concern about health effects of PFAS. Next slide, please. Some of the first studies of health effects of various types of PFAS were animal toxicology studies and occupational health studies done by PFAS manufacturers, which were published as early as the 1950s and are still being conducted. In 2005 to 2013, a series of studies of the health effects of PFOA were conducted by the C8 Science Panel. The C8 Science Panel was a group of 3 environmental epidemiologists who were chosen jointly by the parties to the legal settlement of a case between plaintiffs and DuPont regarding releases of C8, which is another name for PFOA, from a manufacturing plant in West Virginia. Since that time, the literature on PFAS health effects has greatly increased. Next slide. Several types of studies can contribute to our knowledge of the health effects of PFAS. Toxicological studies done in animals are informative, but do not always reflect human health effects because of physiologic differences between species. Mechanistic studies also contribute to our understanding. Evidence relating to biological mechanisms through which PFAS exposure might lead to health effects has been increasing. However, the mechanisms through which PFAS might lead to health effects are generally not confirmed. We also have evidence relating to PFAS health effects in humans from epidemiologic studies. These have included occupational cohort studies, such as those done by PFAS manufacturers, studies in communities with high PFAS exposures, such as those done by the C8 Science Panel. More recently, there have been studies in other highly exposed communities. There have been several cross-sectional studies using data sources such as NHANES and studies of birth cohorts. Finally, there has been an increasing number of studies, such as case control studies and cohort studies, that have been done in populations with exposures at levels seen in the general population. Findings have not always been consistent across studies, and there could be several reasons for that. Most studies have considered PFOA and PFOS, and fewer have considered other PFAS, especially the newer types of PFAS. As older PFAS have been phased out, newer PFAS have come into use for which we have little or no information about health effects. Several groups have reviewed the evidence relating to PFAS health effects to synthesize the information that we've gained through the various types of studies. And these groups generally consider the whole range of studies and consider the strengths and weaknesses of those studies. Next slide. This slide shows the conclusions of several of the groups that have synthesized information on human health effects of PFAS, focusing on health effects for which there is some consensus between the groups. In this table, various health effects are listed in the rows, and various groups that have made determinations are shown in the columns. Now, this is a very general summary, but I would note that there are some differences between the groups and exactly what was included in some of these broad outcome categories. Here, I've listed the determinations made by ATSCR, US EPA, the European Food Safety Authority, the C8 Science Panel, and the National Academies of Science and Engineering and Medicine. I've also noted determinations from the International Agency for Research on Cancer, or IARC, and the National Toxicology Program. Note that the different groups can consider different ranges of types of PFAS. However, there's general agreement about associations between some types of PFAS and some health outcomes. Several groups determined that there is evidence for an association between PFAS and cancer. IARC has classified PFOA as carcinogenic to humans, or group 1, and PFOS as possibly carcinogenic to human, group 2B. IARC classified PFOA as carcinogenic to humans based on sufficient evidence for cancer in experimental animals and strong mechanistic evidence in exposed humans. They also found that there was limited evidence for cancer in humans for renal cell carcinoma and testicular cancer. IARC classified PFOS as possibly carcinogenic to humans based on strong mechanistic evidence. The evidence for cancer in experimental animals was considered limited for PFOS, and the evidence regarding cancer in humans was considered inadequate. There is also evidence for an association between PFAS exposure and increased liver enzymes, increased serum cholesterol levels, decreased immune responses, especially decreased antibody responses to vaccines, decreased birth weight, and possibly gestational hypertension and thyroid disease. Next slide. This table has the same format as the previous one, but focuses on health outcomes for which associations have been observed in some studies, but for which there is generally a lack of consensus, at least at this point. These outcomes include breast cancer, asthma, risk of infection, ulcerative colitis, gestational diabetes, overweight, obesity, several developmental outcomes, preterm birth, decreased fertility or fecundity, and hypertension. Note that although there is consensus that PFAS exposure is associated with increased cholesterol levels, there is so far a lack of strong evidence of an association between PFAS exposure and cardiovascular outcomes, such as myocardial infarction or stroke. Next slide. Many resources are available that provide important information relating to PFAS exposure and PFAS health effects, and I've listed just a few of them here. NHANES has measured PFAS during 1999 to 2000 and from 2003 to the present, providing nationally representative data on PFAS serum concentrations in the United States. The US EPA included 6 types of PFAS in its third unregulated contaminant monitoring rule, commonly called UCMR3. UCMR3 required all public water systems in the United States serving more than 10,000 people and a sample of smaller water systems to monitor for 30 contaminants during 2013 to 2015, including 6 types of PFAS. The data from UCMR3 provided nationally representative data on PFAS in drinking water in the United States. In addition, EPA has included 29 types of PFAS in its UCMR5, which is being conducted during 2022 to 2026, and for which initial data are starting to become available. ATSDR conducted PFAS human exposure assessments in 10 communities near current or former military bases that were known to have used PFAS during 2018 to 2020. ATSDR has published a toxicological profile for perfluoroalkyls. This was first published as a draft for public comment in 2009 and has been updated since that time. The most recent update was published in 2021. The National Academies of Science, Engineering, and Medicine published guidance on PFAS exposure testing and clinical follow-up in 2022, and ATSDR published updated PFAS information for clinicians in 2024. And all of these resources are available on their respective websites. Next slide. So this slide lists the websites for the resources that I mentioned on the previous slide. Dr. Wendell will now summarize ATSDR's updated PFAS information for clinicians.
Good afternoon. Thank you, Dr. Winquist. I'm Captain Arthur Wendell, a Public Health Service Officer and a Family and Preventive Medicine Physician with the Agency for Toxic Substances and Disease Registry, or ATSDR. Dr. Winquist provided a great background about PFAS, its health effects, and some of the challenges with understanding PFAS. So I'll be covering ATSDR's PFAS information for clinicians and highlighting some of the content within it. Next slide, please. As you heard from Dr. Winquist, the health considerations about PFAS are complex. ATSDR has developed products to help synthesize PFAS information. These include ATSDR's web pages on PFAS health effects, the PFAS tox profile, which Dr. Winquist mentioned, and reflects a comprehensive and extensive evaluation, summary, and interpretation of the available toxicological and epidemiological information. And what I'll be covering in the next few slides, ATSDR's 2024 PFAS information for clinicians. I want to stress the information component of the title. The document provides information to allow clinicians to engage patients to make decisions about care and to be able to weigh the risks, benefits, and limitations of testing decisions. It's information, not guidelines. The purpose of PFAS information for clinicians is to provide clinicians with information for engaging patients to help them understand their exposure, develop strategies to reduce exposure, and navigate decisions around clinical management. It promotes clinicians engaging with patients about concerns and using clinical judgment to help create a plan with each individual patient. It emphasizes the clinician's role in helping patients reduce exposures. The document was created for primary care clinicians, especially those with patients living or working in areas with known PFAS contamination. And this version updates previous materials with what's currently known about PFAS and health. Additionally, ATSDR received requests for helping create greater clinician awareness of PFAS health concerns and to help clinicians understand actions that can be taken to address PFAS exposures. And this document helps respond to those requests. Next slides, please. Before launching into the content, I just want to provide a brief overview of the development process. So ATSDR's process for revising PFAS information for a clinician involve reviewing existing literature and reports and engaging with subject matter experts. An internal work group of subject matter experts and clinicians was assembled from across ATSDR and the National Center for Environmental Health to review existing literature, existing PFAS reports, and provide guidance for the development of PFAS information for clinicians and review draft products. External physicians with expertise in toxicology, emergency medicine, occupational medicine, and primary care also reviewed the draft document in multiple stages of development. And after this process, the document then went through CDC ATSDR review. Next slide, please. The content of the document was organized to help make it accessible to primary care clinicians. It includes a key points section, highlighted here in the graphic, that briefly summarizes PFAS exposure and clinical considerations. It also contains sections on PFAS properties, how people are exposed, and associated health effects. These are some of the topics that Dr. Winquist covered. A section on clinical management describes options for exposure reduction, and because patients might inquire about PFAS blood testing and clinical management based on blood levels, it provides a summary of what to consider when approaching these decisions and engaging with patients. Considerations for pregnancy, breastfeeding, and children are also provided. For clinicians who seek additional consultation, sources of additional expertise, like medical toxicologists or occupational health clinicians, those are some of the things that Dr. Ye spoke about earlier, are listed, as well as additional resources to learn more about PFAS. Later slides will go into more detail on the content for exposure reduction, PFAS blood testing, and clinical management. Next slide, please. So let's go through a couple of sections. The clinical management section contains an example exposure reduction strategies by exposure source. Exposure reduction is a fundamental way to reduce risks. So backing up a bit, I want to emphasize that for patients with PFAS concerns, an exposure history can be helpful in identifying the sources of exposure that can create the most risks. And Dr. Ye talked about taking an exposure history. Dr. Winquist mentioned some of the ways that people may be exposed to PFAS. And as you heard from Dr. Winquist, PFAS exposure is fairly ubiquitous. At this time, it's likely not possible to eliminate all sources of PFAS exposure. What clinicians can do and what folks can do is better understand those exposures that are unique to the patient and person, the community or workplace. For example, if drinking water is contaminated, gain an understanding of that person's exposures through this route. Info from local public health departments or local environmental health departments about community issues can be very helpful. So going back to that exposure reduction section, the section balances the range and specificity of actions listed in this table with the succinctness of meaning of the table. And as the document denotes, it's not necessarily all-encompassing, but it refers to additional sources and additional steps to consider. So example exposure reduction strategies for PFAS depend on the source of the exposure. They include water filtration, testing private well water, and limiting consumption of foods known to be contaminated with PFAS. Again, reaching out to local public health departments or environmental departments can be helpful in gaining information about known contamination and the community-specific strategies that they suggest. Next slide, please. Also within the clinical management section is a subsection on PFAS blood testing. Clinicians can use the information in this section to help address their patients' concerns and questions. The information includes that clinicians can order PFAS blood levels through CLIA-certified commercial clinical laboratories. And just as a note, that should read clinical laboratory improvement amendments, not methods. Certification helps ensure the validity of the test result. These results could reflect recent exposures or past exposures, depending upon the half-life in the blood of the specific PFAS. And clinicians can consider whether blood PFAS test results can inform exposure reduction and health prevention. For many clinicians, this consideration is important so that the tests are done for a purpose. Next slide, please. PFAS blood testing benefits and limitations are also listed, so clinicians are aware of what information a test can and cannot provide. Benefits of PFAS blood testing might include greater recognition of PFAS-associated health effects and possible psychological relief from knowing one's PFAS blood levels. Limitations of testing include that PFAS blood test results do not predict future health outcomes. PFAS blood test results do not identify sources of exposure. Next slide, please. Another subsection is clinical management based on PFAS blood levels. ATSDR has not developed health-based screening recommendations for PFAS and encourages clinicians to follow usual standards of care for health concerns. Clinicians and patients can discuss the risks and benefits of using PFAS blood testing results to guide clinical management. Considerations include factors unique to the patient, whether health screening beyond the usual standards of care is appropriate, and the potential for harm related to medical evaluation, including unnecessary additional screening or treatment and adverse consequences from medical evaluation and treatment. Next slide, please. In summary, as you've heard from both talks, communities across the country have been identified as having PFAS contamination, putting them at risk of higher levels of exposure. Higher levels of exposure to certain PFAS may be associated with increased risks of certain health effects. Identifying exposures and strategies to reduce those exposures may help reduce health risks. And clinicians can play a key role in helping their patients understand their exposures, their unique risks, and options for exposure reduction. ATSDR's PFAS Information for Clinicians provides information to help clinicians effectively engage with patients about PFAS concerns. For example, performing an exposure history can help clinicians identify current and past exposures, assess the extent of PFAS exposure, and how to best counsel patients on exposure reduction strategies. Next slide, please. You can find PFAS information for clinicians on ATSDR's website, including a PDF version that can be printed. Look for and share social media posts like the one pictured on the screen. For clinicians and others with PFAS-specific questions, they can email pfas@cdc.gov. Lastly, if you're willing, please share any feedback about PFAS information for clinicians. We're hoping to hear more about how this document works for clinicians. And I guess I'm the final speaker, so thank you very much for your attention.
Thank you so much, Captain Wendell. Did have a couple of questions come in regarding this section. The first question is, what is known about the mechanism of action of PFAS given its wide variety of health effects?
Yeah, so I guess Dr. Winquist can help answer this as well, but the PFAS tox profile goes into great detail about what is known and what is not known. And to kind of summarize it, we're still learning a lot about that mechanism of action. We don't know precisely what it is, and so that's something that's still actively being researched to help understand better.
Thank you. Another question that came in, is there anything that can be done to lower a person's concentration of PFAS in their blood? And I'll open that up to you or Dr. Winquist or Dr. Chang, anybody who's willing to answer that.
Yeah, I mean, at this time, there's no approved medical treatments to lower the concentration of PFAS in one's blood. Over time, as related to the half-life of each individual PFAS, people will excrete mostly through the urine, but also for women who are menstruating through blood or other mechanisms, PFAS over time. And that half-life can depend somewhat on the individual person's health. That's why you sometimes see a range of different half-lives being presented. But that over time and with a reduction of exposure, that's the most surefire way of reducing PFAS concentrations in individuals.
Thank you so much.
And I would add one other comment in that, with an individual patient, the recommendations or the information for clinicians includes some types of exposure sources that you could explore with people, and you could explore whether there's ways that they can possibly reduce any ongoing exposure to PFAS that they have.
Thank you, Dr. Winquist. That is all of our questions for this section. And now I'll turn it back over to Dr. Chang for closing remarks.
Great. So thank you so much for joining us today, and definitely want to thank all my CDC colleagues that made this webinar possible. So the reason why we're doing this is because we feel like clinicians may increasingly encounter patients affected by these environmental health threats. And we want to give you the right information, resources, and tools so that you can provide the optimal advice and management for your patients. So I hope that this webinar was useful to you, and want to let you know that we will be working on additional topics that may be of interest. So we are working on a session on environmental and natural man-made disasters, which include hurricanes, chemical and radiation emergencies. So if you're interested in that, and your role as a clinician, please stay tuned, and we'll put that information out on the EHNexus website. We're currently planning that, so likely that will be in the next few months. We know that you're very busy and your time is very valuable. So please let us know how we did today by filling out the evaluation that's included when claiming your continuing education credits. Next slide, please. So now for all those 74 people that stayed with us until the very end, this is how you're going to claim those credits. So please follow the instructions on this slide. First, go to the CDC's Training and Continuing Education online website, and that's train.org, train.org. Create an account, and then register for this course by searching for WC4879. So after you do that, you'll be led to the page for this actual session. And there is going to ask you for an access code. And that's where you put in EHNex 0924, as you see in the screen here. And then you have to pass the post-assessment quiz, and then also complete your evaluation, which will be very important for us to find out, what you're interested in and how we did. And please complete these steps by October 18th so that you can receive your certificate. Also, I want to mention that we're going to be making this webinar recording accessible through the training website, but it will probably be in the next few days. So with that, I want to thank you once again for joining us, and I'll pass it back to Brooke.
Thank you, Dr. Chang. And I would like to follow up. If anybody has any additional questions that we weren't able to address during this webinar, please send them to ehnexus@cdc.gov, and we will forward those on to the appropriate SME. This concludes today's EHNexus webinar. Thank you all for joining us, and a special thanks to our presenters for their insightful information and their time today. Take care, everyone, and have a great rest of your day.